Hey, all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. And this is a very special episode. It is the final episode of the Top 200 Drugs podcast series. So hopefully you found it beneficial. Hopefully you found it enjoyable. Really meant and geared towards maybe beginning healthcare professional students, nurses, pharmacy students, just to give you a good broad sense of those top 200 drugs and what they are, how they work, and some of the most important clinical pearls, as well as things that are going to show up on your board exams or pharmacology exams throughout school. So again, thank you so much for listening. This will be the final episode on the top 200 drugs. Going forward, I'm going to be looking at drugs I haven't covered. So remember, I've got, I believe it's over 300 individual drugs I've already covered years ago. So those are all in the archives for you to listen to, go find, go track down. You can search for them on the website or whichever podcast platform you're in. But again, a lot of the common medications, I've likely done an individual episode on that. So go take advantage of that if you want to look at that. And going forward, probably going to cover some more individual drugs and may also cover some specialty things, whether it's drug interactions or maybe a little bit more targeted reviews on cardiovascular medications or hypertension medications. Probably do a little bit of variety. So if you want to reach out to me, mededucation101@gmail.com. If you got suggestions, ideas, feel free to shoot me an email. Let me know what you're thinking. I'm definitely going to be a little more sporadic, bopping around on different topics, but obviously staying on pharmacology in general. It's what I know. It's what I like. It's what I care about learning and educating on. So with that said, let's get into the last 5 drugs of the top 200. First one is 196. This is Lansoprazole. Brand name is Prevacid, and this is a proton pump inhibitor, or a PPI. Mechanistically, this inhibits hydrogen potassium ATPase in parietal cells, which ultimately blocks or reduces gastric acid secretion. So by reducing that acid secretion, we can help manage things like GERD, peptic ulcer disease, Barrett's esophagus, those type of conditions there. As far as dosing goes, typically we're going to give this medication 30 to 60 minutes prior to a meal for maximal effect. Now, if for some reason we can't do that, the drug probably still will work okay. But for that best efficacy, typically we want to give it before the meal, kind of get those pumps shut off a little bit prior to food going into the GI tract. And that can ultimately help reduce that acid secretion there. So again, ideal to do it 30 to 60 minutes before a meal. But again, still going to be effective if, for whatever reason, a patient can't do that for some reason. It is important to note that, unlike, let's say, antacids like a Tums or a calcium carbonate, a PPI like Lansoprazole is more potent, but it does take a little longer to work. So definitely might take up to a few days for it to kind of get to its max effect. All right, adverse effect profile. So I typically think more so along the lines of longer-term risks. Osteoporosis has been reported. A couple vitamins, nutritional things, B12 deficiency, magnesium deficiency. Those have been reported with PPIs in general. C. diff risk has been associated with the use of PPIs as well. So, generally I don't really pay attention to that too much, but if I see somebody diagnosed with C. diff or a patient who's got recurrent C. diff, always a good time to kind of reevaluate the risk versus benefit of using a medication like Lansoprazole. Usually it's going to be dosed once a day. We can up the dosing for more refractory cases or severe cases. Oftentimes in those severe cases, we may see a PPI used in the morning with an H2 blocker at night, like famotidine. That's definitely something I see in practice periodically. One of the more important things I do in my work is making sure that we're on medications for a reason. And when we're managing symptoms like GERD, it's recommended to reassess that medication after 8 weeks and potentially stop it. And really, really important, I think, to do that because we've got some longer-term risks with PPIs for sure. So again, minimum effective dose for patients. If we can get patients off these medications, that's definitely a nice thing that we can try to do. Now, there are certain situations where you can't. A history of peptic ulcer disease and they need anticoagulation, or they have Barrett's esophagus. So there are some certain situations where we're likely going to have to do long-term PPI use. But again, want to make sure to look at that risk versus benefit and see if we can ultimately get them off it if possible. All right, drug interactions briefly here. Two that I think about, there's a cephalosporin, cefuroxime oral. That needs a significant amount of stomach acid to be absorbed. So using a PPI like lansoprazole with this medication could reduce absorption. Iron's another one as well, where if we don't have adequate acid in the stomach, it may reduce the absorption of oral iron supplements. So a couple to kind of think about there. All right, moving on. Next medication, we've got Augmentin. This is amoxicillin clavulanate. Mechanistically, so the amoxicillin portion, it binds penicillin binding proteins in bacterial cell walls. This leads to the inhibition of bacterial cell wall formation and ultimately can help kill the bacteria. So that's amoxicillin. Now, clavulanate is what's called a beta-lactamase inhibitors. And in that category, basically they're used in combination with amoxicillin. And this helps prevent the bacteria from breaking down the drug with its enzymatic processes. So important kind of add-on medication that maybe helps get over some potential resistance with some bacteria. So that can definitely be helpful in some cases. I will say, compared to just plain amoxicillin, in my experience, Augmentin does tend to have a higher incidence of GI adverse effects, and more specifically, I would say diarrhea. So that's important to think about there. It's typically going to be dosed twice a day. Other potential adverse effects, rash, itching, allergic reaction, those type of things with amoxicillin clavulanate. Drug interactions. Probenecid is an older medication that was historically used for gout. It's been quite some time since I've seen this medication, but it can raise concentrations of amoxicillin. And then warfarin, I'll mention, it can potentially raise INRs, part due to, infection, not feeling well, not eating well, as well as the antibiotic potentially killing certain bacteria in the gut that may produce vitamin K. So there's a lot of potential mechanism as to how it can potentially raise INR in patients taking warfarin. All right, next medication, we are on 198. That is Lovastatin. Brand name is Mevacor. So, classification, it is a statin medication used to manage hyperlipidemia. Mechanistically, it inhibits HMG-CoA reductase. This prevents the conversion to the precursor of cholesterol, mevalonate. So ultimately, this accelerates expression of LDL receptors with increased uptake of LDL from the blood to the liver, which leads to lower plasma LDL. That's our ultimate goal with statins typically, is to lower LDL. So that's how that medication works there. Indication, obviously, elevated cholesterol, hyperlipidemia. Again, statins are typically, we're going to focus on that LDL number. That's kind of our primary goal, is to reduce that. Can help reduce the risk of cardiovascular events, heart attacks, strokes, things of that nature. Warnings, precautions. So, probably the biggest thing and probably the most highly testable thing is the risk for myopathy and the risk for rhabdomyolysis. As patients get older, worse renal function, higher doses, drug interactions. Those are all situations where that risk can potentially go up. And so those are some of the things that I kind of look out for as I'm maybe reviewing a patient case or looking out for certain types of aches and pains that I'm seeing, and just trying to differentiate if it's potentially a medical condition or if it's statin related. Those risk factors may play a role in kind of deciding like, okay, yeah, this is maybe a patient a little bit more at risk for this adverse effect or maybe not. And I mean, we can check for rhabdomyolysis, we can check CPK, so lab value there. If that's significantly elevated, that can be a potential indicator there. Other adverse effects, other than kind of the myopathy, myalgia type symptoms, some GI upset potentially, maybe a headache. Again, I don't typically see many other adverse effects with statins other than the myopathy, the muscle soreness. Important to make sure that patients implement lifestyle changes as well. Okay, so those cholesterol lowering diet interventions, exercise, all those things that can help reduce cardiovascular risk. Drug-drug interactions. So CYP3A4 with Lovastatin is important. So this is kind of one of the downsides of this medication. It's not crazy potent. It doesn't get to high intensity like rosuvastatin and atorvastatin. It doesn't lower LDL as much as those other drugs. And it's got CYP3A4 breakdown. So that can lead to some drug interactions. I've talked about CYP3A4 plenty, I think, in previous episodes, but your azole antifungals, for example, those can certainly raise concentrations of Lovastatin there. Daptomycin's one other one I'll mention, as well as fibrates. There's kind of an increased risk for myopathy and or rhabdomyolysis when used in combination with Lovastatin. One last little tidbit, Lovastatin is lipophilic. So if we're looking to, switch between statins, so say they didn't tolerate Lovastatin, they had some minor achiness, that type of thing, but they didn't like it, that's a situation where we might look to try a hydrophilic statin, which would be like rosuvastatin or potentially pravastatin as well. Number 199 is Valacyclovir. This is Valtrex. This can be utilized to treat various viral infections, things like shingles, herpes simplex virus or HSV, a couple of kind of common examples there. Mechanistically, it inhibits viral DNA synthesis by being incorporated into viral DNA, which ultimately kind of disrupts the replication process of the virus and hopefully ultimately reduces symptoms and helps the immune system resolve that infection. With antiviral therapy, typically the sooner the better. So let's say you've got a patient with a shingles episode, so ideally we'd probably want to get that started within 3 days if possible, 72 hours. It's kind of a good target there. Note that Valacyclovir is kind of a cousin to acyclovir, or there's some significant similarities, I guess, to the medication. The one nice thing about Valacyclovir is it typically needs to be dosed less frequently than acyclovir, so that's kind of an advantage of that medication. So just kind of summing up that relationship, Valacyclovir is actually a prodrug, and it's converted to acyclovir in the body there. Adverse effect profile, GI upset, probably most common, usually not terribly bad. I would say probably less common than amoxicillin or antibiotics. For most antibiotics, maybe I should say. But again, can happen and certainly is there. One kind of rare, unique thing it's definitely associated with Valacyclovir is liver issues, particularly if you've got longer term therapy, if you've got issues, risk factors for liver toxicity already, maybe they're on other medications, for example, then it may be a little bit more likely that happens. One other rare thing is neurotoxicity can cause some CNS changes. Again, short-term use, probably likely not an issue, but longer-term use, patients with CKD, renal disease, that drug may be more likely to accumulate and cause these issues. It is recommended to maintain adequate hydration with this medication as well, so that's an important thing to note. Drug interaction standpoint, I typically don't worry too much about Valacyclovir. If you've got patients that are on, numerous liver toxic drugs, maybe you'll worry a little bit more about that, but in general, drug interactions aren't too prominent. One thing I will mention, mild CYP1A2 inhibition, so that could raise clozapine concentrations. It could raise tizanidine is another example as well, where those concentrations could go up. Again, not a total contraindication, probably something you're just going to monitor with this medication. If you're looking for study materials to prepare for your upcoming board exam, go check out meded101.com/store. We've got ambulatory care, NAPLEX, BCPS, geriatrics, BCMTMS, all sorts of resources there that can help you pass your exam. We've had thousands of candidates use our content, and we can certainly help you prepare for your exam as well. So again, go check out those resources, meded101.com/store. Your support goes directly to support this podcast. All right, and last but not least, number 200, we've got Chlorpromazine. Brand name is Thorazine. This is a first-generation antipsychotic. So it certainly can be used for bipolar disorder, schizophrenia, numerous psychiatric disorders. Can also have some antiemetic type activity, so you may see it used for nausea and vomiting periodically. And one rare one I have seen come up on pharmacology exams and board exams also may be used for intractable hiccups, where patients are having trouble with that. So that's kind of a really unique clinical pearl there that you may see chlorpromazine used for. Mechanistically, chlorpromazine has dopamine blockade. As you could imagine, it's an antipsychotic. It also has anticholinergic activity as well. So, as you could imagine, it's got anticholinergic activity. That whole list of side effects, dry eyes, dry mouth, constipation, urinary retention, those are all potential adverse effects with this medication. On the dopamine blockade side, so there we can get the movement disorders, the extrapyramidal symptoms, neuroleptic malignant syndrome. Very rare syndrome, but it can happen there. A couple other things I wanted to mention. Can drop blood pressure a little bit, sedating, hyperprolactinemia has been reported there as well. And then I did want to mention QTC prolongation. Chlorpromazine is not the greatest antipsychotic when it comes to that. It can worsen QT prolongation. So in patients with a baseline of 450 milliseconds or higher, we are typically going to avoid chlorpromazine. Hopefully we can find another option that works for them. Now, if you've got a patient that's taking it and that QTC interval goes above 500 milliseconds, that's a good time to reassess this medication and say, hey, can we switch to another antipsychotic? Can we reduce dose? What can we do here? Because that's definitely putting your patient at risk for potential cardiovascular complication there. This medication does carry the boxed warning for increased mortality in elderly patients with dementia-related psychosis, so that's important to note. And then for drug interactions, from a safety standpoint, there's a lot of look-alike, sound-alike medications. So really, really important. Many medications have chlor in it. Chlorpropamide, promethazine, prochlorperazine, clomipramine. These are all different medications, but they definitely sound and look a lot like chlorpromazine. And some of the doses of these medications can overlap, where it's very similar dosing. And so be really, really careful with this medication for sure, because there can definitely be some mix-ups on look-alike, sound-alike. Again, one more important reason why we want to try to attach a diagnosis with every medication that we use. because it may help us catch a medication error like this. All right, wrapping up with drug interactions, we've got additive sedation, opioids, benzos, alcohol, and so on. QT prolongation, I alluded to that already. So, antiarrhythmics, amiodarone, antibiotics like quinolone antibiotics, azithromycin, citalopram, these are all QT prolonging medications and could increase that risk for QTC prolongation. Hypotension adverse effect, I alluded to. So, keep an eye on those additive effects of, blood pressure lowering medications. Seizure risk can go up with this medication in combination with bupropion. That's kind of another one to remember there. And then, of course, anticholinergic burden, so additive type effects, from TCAs like amitriptyline or first-generation antihistamines like diphenhydramine. All right, well, that's going to wrap up the podcast for today. Do us a huge favor. Share this series with friends, colleagues, students, any healthcare professional that may benefit from some pharmacology education. I greatly appreciate that. Leave us a rating review on iTunes or wherever you're listening. Greatly appreciate that as well. And of course, if you've got suggestions going forward here, shoot me an email, mededucation101@gmail.com. I try to respond to all the emails I get, so give me a few days sometimes. It does take me a little bit. I get quite a few. But yeah, definitely I'm listening. I'm open to various suggestions surrounding medications and pharmacology for sure. So don't hesitate to touch base with me there. As always, support the sponsor, meded101.com/store. We've got a ton of books, review courses, NAPLEX, BCPS, ambulatory care, geriatrics, all sorts of stuff for all different kinds of healthcare professionals. So again, go support the sponsor, meded101.com/store. Thank you so much for listening. Take care, and I hope you have a great rest of your day.